So I want to welcome everyone on the call. A handout that Kerry provided as well on activities, as well as the presentation, were distributed yesterday. I'm Becky Royer, and I am with the Medicare Beneficiary Quality Improvement Project. I lead that effort for the State Office of Rural Health for Joyce Fillenworth, who's the State Office of Health manager, and David Conrad, who is the flex coordinator. And they've continued to volunteer a lot of their time working the call center for COVID, and hope they're not seeing too much of an increase in the number of calls coming in, but suspect that it's coming our way. Want to thank Allie Orwood with the Indiana Rural Health Association for supporting Zoom. And so we have a pretty packed agenda today. I know we have a few newer individuals on the call, so I want to spend a little time introducing Kerry. Kerry Dunning has been working with our State Office of Rural Health team for a couple of years now in helping really build a good foundation for the Swingbed programs in Indiana, primarily focused on our critical access hospitals. And Kerry has worked in the post-acute care setting for a number of years now, is really what I consider a Swingbed expert, has lots of good connections with CMS, has assisted both providers within the United States as well as internationally. So we're real honored to have Kerry with us. She is on site presenting at a conference today, but wanted to take out some time to have our April scheduled Swingbed meeting. So again, we have a lot to cover. You are more than welcome to unmute your line at any time. To unmute, you can click the little microphone beside your name in the participant list. And for most of you, if you hover at the bottom of your screen, you'll see a bar come up where you click on participants. You can also hold down the space bar on your computer if you're connected through your computer for your audio, and that will unmute your line there as well. You're also welcome to put questions into chat. We monitor chat the entire time, and we'll make sure that your questions are addressed. So Kerry, I'll go ahead and turn it over to you.
I appreciate it, Becky. It's nice to be here. I will apologize. There may be periodic background noise. I actually found a room with nobody in it and the door closed. And as soon as I found it and keyed on in to speak with you, of course, people start walking in. So I'm giving them the big evil eye every time they get too close to me. So hopefully that'll work for a while. I have a list here of updates, and it's a more sizable list than we normally go through. We usually have 2 or 3 topics, which is why I've decided to just treat it as updates. And some of these are documents you can go out and find. So if you need to do follow-up, they're available. I'm going to start with CMS in the last week has issued new dementia training materials. I know we're not in the dementia business, particularly with swing beds, but the real issue we have is we're seeing more patients with dementia in skilled care, period. It is pretty pervasive in the nursing homes, and I'm seeing more of them being admitted because it's a comorbidity when we're dealing with swing beds. So you might want to look at those materials if your trainers haven't pulled them down yet. CMS is also looking at quality efficiency measures. Some of you may not know at this point, but there are like 16,000 nursing homes and a sizable number of what we call rural hospitals or PPS swing bed programs. They all have to complete an MDS. And because of that, there are quality measures, QRPs, quality measures, quality initiatives that the government and CMS in particular already tracks. And so the only group that doesn't have specific quality measures right now are those of us that are critical access swing beds. I know at some point we're working on it. I know Becky's working potentially on a project where we're going to be looking at quality also. So just know that's coming down the road, but I would start with basics you really need to know. We've had discussions in the past about 30-day readmissions, the cost per Medicare beneficiary per episode. There's some basics there that you should start looking at. And I would start perhaps with your financial people and see what you can pull down from your already existing computer reports, meaning things like you can find out your top 5 diagnosis categories, ICD-10 categories that you're admitting, in a year's time period, and monitor how that's changing, because that can help set up training. So just know that it is a heightened topic, and lots of us are working on it. So there's going to be sort of probably monthly updates on that. The COVID-19, there is an add-on payment for new treatments. And the reason I have it here is it is not for critical access. And we seem to be getting a lot of confusion for it. It is for the PPS settings, or the nursing homes in particular, but others. And the reason that critical access swing beds are not getting the add-on payment now is you're reimbursed at cost already. So please watch for that, because that thing has gone back and forth pretty routinely. Dementia-related psychosis is on the increase, and CMS is putting out material on that in case you have any of that. Again, that's not usually found in swing beds, but just so you know, there's material. They are reviewing what they call facility-initiated discharge. This really is a series of documents that were put up by CMS, particularly for nursing homes. It started years ago when we were seeing what is unofficially called dumping. People weren't paying their bills, and the nursing homes wouldn't keep them. More importantly now, what that means for your swing bed program is the involvement. Becky, I'm getting your email on the top of it.
Yeah, people are having trouble logging in. Sorry. I'm
Okay.
sending the passcodes out.
Yep. Well, I just want to make sure it wasn't an email that said, Kerry's a very pitiful speaker. I'm so sorry
No,
we're having
no.
to do this. Okay.
Sorry about that. When it popped up on the wrong screen.
That's fine. The importance about the facility initiated discharge is we are all supposed to involve the ombudsman when we are discharging a patient. You need to be talking, and we've had this discussion in the past, and I know Becky's looked into it, but we need to be letting your regional ombudsman know who you're discharging. Often what they elect to do is get an Excel spreadsheet sort of report from you at the end of each month. But if somebody is having confusion, somebody's concerned about the discharge, particularly if it involves a psych issue, you may want to involve the ombudsman voluntarily, but that's state by state. So I would suggest all of you have a talk with your primary ombudsman and see how they want to handle it, because CMS has allowed that to happen, and all of us doing a slightly different version. May I remind you that skilled nursing, which you're under those regulations, is heavily into med reviews these days. And this comes from us seeing 18 and 20 and 24 meds per person when they're being admitted. And I've talked extensively about the fact that skilled, meaning swing bed stays, are one of the few times we can take a deep breath and look at that med list and work with our pharmacists and physicians to see if we can reduce unnecessary meds, or particularly any of those that CMS has targeted for review. And that goes anywhere from opiates to psychotropics to antibiotics. So if you're not looking at meds closely now, and if you don't have a process in place where we can perhaps work on reduction or change or controlling cost of medications for people going home, I'd suggest that become a discussion point within your facility. You may not know, but the OIG is investigating, and that's their word, by the way. They're the FBI for healthcare. They're investigating payments to critical access swing beds from 2015 to 2019. That in itself doesn't worry me. I've had other investigations. You kind of go, uh-oh, but it should prompt you to work with your financial people. You should be pulling the types of patients, like your top 5 diagnoses in 2015, 16, 17, 18, and 19. What was your cost, or what was your reimbursement? That'd be easier in 2015 versus 2019. You want to know what changed, because I suspect 2 things are going to show up if we can take the lead and write the words in for this story. One is, in 2015, almost all of us were doing all rehab patients. It was 95% rehab admissions at that point. By 2019, we were moving into the clinically complex business, which is a more expensive patient. So that's why it's important you look at your diagnoses or your ICD-10s by each year, and you look at your total reimbursement. I hope your financial people can maybe even break it down to cost per episode average from 2015 to 2019. And I think you will find in more cases than not, the reason that CMS paid you more money is we were taking care of more complex patients. But it'd be really nice for you to have that information in hand. So when this comes out and they say, gosh, we paid them a lot of money, and newspapers and so forth start calling you, you'll have a bit of a defense, and it gives you a chance to talk with your fiscal intermediaries about what's going on. You do not have to do PDPM. I'm going to say that real clearly. That's for those who have to complete the MDS. It's a payment system for them. It is not the critical access payment system. But if you look up that language, PDPM ICD-10 mappings, it is showing where they expect certain diagnoses to end up on the spectrum. So there is a spectrum from rehab patients up to full medically complex, clinically complex patients. So I'd say the far end these days is the COVID patient. But if you look up those mappings by pulling that up on the CMS website, it will show you where there is an expectation of more care or less care, and that may help you also self-audit what kind of care we're delivering. There is a QSO, which just comes from the Quality and Safety Office, that has to do with the EIDs. I'm putting this on here for you to pull down and get to the right staff members at your facility. It's not something we're going to discuss in depth at this point. Skilled documentation is going to get us in trouble. I'm going to say this several times, probably every time between now and the end of the year when we're talking. We are headed for some substantial reviews in after the first of the year. I think audits and surveys coming up. The CMS is going to have to defend how much money they've paid different people. And what I am finding lacking over and over and over is the support as to why CMS paid for you to have a skilled patient in a swing bed program. And the simplistic answer of that really is it's a head in the bed. So why did they have to be in your swing bed program? Could they not have gone to home health or outpatient? And in either of those cases, the defense is your documentation. I don't mean to literally, you have to say, well, they didn't go to home health because of, but literally your 24-hour, particularly nursing documentation, therapy, pharmacy, your physician documentation is getting tied into this. There are already physician audits going on. So please review and self-audit your own charts. The other audit that is started quietly, but we're expecting to pick up speed is IDTs. That's the crux of where CMS is going to say everything should be coming out of your IDT meeting, and they already have tied it to discharge planning. IDT, as you know, requires a physician, I'll say in the room is in quotes because they can be connected electronically, certainly nursing, therapy, social services, activities. If you have a solid activities program, want to discuss that part of it. You need to have your full team meeting together. This is not a situation where CMS wants us, two people to be in a room, come up with a plan, and then go around to the other members who should have been in the room and have them sign off on it. It is meant to be a talking discussion on what's best for this patient. The other thing they will be looking for is a patient or patient representative, I should say, and or patient representative is supposed to be involved in your IDT, and we need to have documentation that they were in fact there, and we can't do that if there's not a significant meeting process. So if you aren't doing that, start looking at it and making a change. And one of the most asked questions I get through help desk these days is on the 3-day waiver. The 3-day waiver refers to the required 3-day acute stay prior to admission to swing beds that was waived through the PHE public health emergency. At this point, HHS is hinting that we will be under the PHE through the end of 2021. And if they change it prior to the end of 2021, they are supposed to give us 60-day notice. So we have some, they're not going to drop it overnight on us. But that means right now, you will have the 3-day waiver where they can be admitted from different settings without 3 acute day stay and up until the end of the year. It's also a warning. The other thing we're going to be talking about in the next couple of months is really that you have your team start working on, and we'll be talking about reentry plans probably by June in our or one of our regional meetings anyway, where we cannot wait until October, November, and December to say, oh gosh, we're not going to have a 3-day waiver. This changes, this changes, this changes. Our physicians don't change that fast. And if they've been admitting from ED directly or whatever their circumstances are, we're going to need to have a plan starting early in the summer that says to them, here's what's coming. We're going back to our real rules, or some rules may be adjusted, telemedicine being the example of that. So that's a pretty sizable hit list. And Becky, if you can go to the next slide. So just if you have questions about that, we'll keep talking about all those issues. But I do want to talk about comprehensive care plans right now. And the reason is this goes into your baseline care plan, which is supposed to be completed within 48 hours of admission to your skilled bed. And they mean 48 hours. So if they come in at 4 p.m. on Friday afternoon, that means by 3:59 on Sunday, you have to have a baseline care plan in place. And that baseline care plan goes to your IDT meeting. It's supposed to be the basis for your IDT meeting. And that again, all those components, all those people that submit to that baseline care plan, they should have input in the IDT meeting. Remember, your patient is supposed to be there, so some of this should have been discussed with them. So I have highlighted in red, actually CMS did it for me. Those are changes that they have made in the last go around of the comprehensive care plan regulations. So I put this on here so that you can review this and make sure that you're in compliance with this particular regulatory requirement. And again, the plus IDT is a critical component, because out of your first IDT meeting, really particularly if they're only going to stay, say 7, 10, 14 days, but more importantly, in general, when you come out of your first IDT, you should have your comprehensive care plans being developed. The next slide, Becky.
Carrie, before we go to the next slide, if we could back up just a second. Question in chat is there a special code for coders to submit for the 3-day waiver? Our billing office continues to get denials.
Yes, and I'll send it out, Becky. It'll probably be later today. It's,
okay.
It is an add-on, but I need to go see what, I never can remember what field it's supposed to be on the claim. So I need to go look that up before I just say it off the top of my head. But
okay.
Yes, there is a code specific, and I just wrote a note, so I will get that out to you in an email.
Okay, great. Thank you.
Yep. All right, so next slide. This is, we're going to start talking basically about this. And I think Becky has some great ideas about in Indiana as far as trauma-informed care. This is a long time requirement. This is since October of 2018. We are supposed to be doing a comprehensive care plan that's inclusive of any, well, it's supposed to be culturally competent, but also the trauma informed. And trauma, if you've done any study in it, is a wide variety of things. It is PTSD, it is childhood abuse, it is drug and alcohol problems. It's not just one thing. And there are some questionnaires out there that have been developed by different governmental sources. And again, I think Becky can give you a link to something that can help you learn specifically. But my main concern about it, number one, that it is required, and you should certainly have specific documentation on what you're asking, how you're addressing this when a swing bed patient comes in. But that swing bed, except for right this second in life during the PHE, is coming from a prior facility. They're coming from an acute stay. And acute also has to have trauma-informed care. So if we're not asking whoever's referring that patient to us, if they can also send what they call TIC, or the trauma-informed care information, you're starting all over and sort of in the blind. And by the time we're getting to post-acute, we shouldn't be in the blind. We should have some, if they came through the ED, there's some information. If they came through acute, there's some information. If they came from psych, there's some information. But we really, really need to do it. Now, the reason I have put this particular regulatory requirement on it under the comprehensive care plans is because I've had a lot of discussions with CMS, and they constantly go back to this line that's in red, which says that your care plan must have measurable objectives and timeframes to meet a resident. Remember, we're under long-term care rules, so they use the word resident. For us, we would call them patients, medical, nursing, and mental, and that are identified in the comprehensive psychosocial needs assessment. That's the line that's in the regulation that defines that we should be doing an assessment. Again, it doesn't have to be a full-blown, 10-page assessment, but we've got to have some proof that we have asked them questions. And the other interesting thing about this, because I don't know how long it'll last, we can take their answer at face value. We do not have to ask more questions to say it. Like, are you sure? Like, if somebody comes in and we can see that they're depressed through various signs and symptoms you all are very aware of, and the person says no, that's what we would put down on our tick assessment. And it's very clear in all the literature from CMS at this point, we do not have to go down the rabbit hole with that. That's what they told us. That's what we're working off of. Now, you guys are smart enough to know that we certainly want documentation in our nursing notes, maybe social services or case management, to say that we are monitoring this because of whatever, the issues may be. So it doesn't have to be that complicated at this moment. I will tell you the other thing I think is picking up steam, because it's picking up steam in the country in the last couple of years, will be that culturally competent. And that will be a piece on really depending on where you are in your own communities, the mix of ages, the mix of education, the mix of race, gender, and we're all a little different. And so you may want to provide some training classes if you have an unusual mix. So for instance, I'm working with a program right now that was 100% Native American. And they're now about 7% Caucasian. Their Caucasian mix is growing. We're doing a reverse culturally competent and trained population there. It's obviously very rare. And if you don't know it, we have, I think, 4 or 5 states right now, I can probably name them if I think about it, that are minority majority states. For instance, Hawaii has never been a majority Caucasian. They've always been a majority of Polynesian mixes. And the issue with Hawaii is those mixes, you would think when we say Polynesian or we say one thing, it's all the same. It isn't. They have come from multiple backgrounds and actually multiple religions and so forth. Not that, again, you have to get into that depth, but it is a time for us to be doing some training on this, some realization of the people that are in our own communities, particularly if there are changes going in the percentage. Another state I can think of right now, New Mexico is a minority majority. It is Native American majority and has been for years. So we've got pockets of this, and that changes how we have to think, act, ask questions when we are in our care plan meetings with these patients. There are differences. There are significant differences on. I remember a study I was part of years and years ago in the state of Florida. The Hispanic population was mostly from Cuba at that point in the state of Florida. And they were not what we had seen. I don't even know, I hate to use the word typical, but they were atypical of a Hispanic population. And the South Florida hospitals had to change lots of things to be able to help with the Cuban population coming into their hospitals. So just a heads up that it's really, really important that you do your training. And again, I think the key for you is if they're coming from another facility, another healthcare level, you need to ask for them to provide the tick information they've gathered, because the true story you'll get as they go through these processes and steps, we might get a better evaluation of that patient. Yes.
Terry, we do have one question in chat regarding the physician being present during IDT meetings.
Yes.
Does this mean the physician that is assigned to the patient, or can it be the physician, the one that is assigned to the unit that week?
All right, so the answer is assigned to the unit because it's supposed to be a physician with knowledge of that patient. That's the language. And very few of us have PCPs, available. Now, I can reverse that. In some rural areas, the PCPs are the ones And they've gone so far to set up their meetings like during, I don't know that doctors really get lunch hours, but during lunch hours so they can Zoom them in to that IDT meeting. So it is one with knowledge of that patient.
Okay, thank you. I had a question emailed to me, and I will put my email in chat because there's some individuals that cannot unmute. But the question that came through my email is, when a patient remains in the same facility but must move to ICU from Swingbed, is this a facility initiated or resident initiated discharge or transfer? Patient and the representative wanted the patient to be treated aggressively for hypotension requiring a Levophed drip in ICU, which is not part of the original plan of care.
Right. So the simple answer on that is when they go to a higher level of care, so that would be acute or ICU, they are discharged from the swing bed and admitted to acute or ICU. So that is not a transfer. That is that's like somebody going from home right into, you know, an acute bed. Does that make sense?
So is that facility initiated or resident initiated, or is that?
That would be facility, but it's not one where you're having to contact the ombudsman because they're going to a higher level of care, which means they have met criteria to be admitted to ICU or met criteria to be admitted to acute. So it is a discharge from swing bed, straight out discharge, and then it's an admission to the higher level. Now, if they were going to outpatient or you know, another setting and not home, that would be well, they would consider that facility initiated because we're the ones discharging them.
Gotcha. Okay. And Chrissy, if you have additional questions, feel free to email me again. And again, I'm putting my email address in the chat so that people can email questions to me if they need to. Again, we apologize for the Zoom issues today. So, and that's also
Zoom's been gone through, I'd have to ask Allie how many variations since the pandemic. They've been steadfast in having to change. So there's a lot always going on.
And before I advance slides, I will share too that I did find on the Indiana University website, and I'll send the link along with the 3-day waiver codes for billing, that you can receive a certificate in trauma-informed care. It's a nice modular system that you can advance the modules and work at your own pace. It doesn't all need to be completed at one time, but does a really nice job of going through trauma-informed care, the 5 principles as a philosophy of care, which is safety, trustworthiness, choice, collaboration, and empowerment. And you do have to take a few just short quizzes at the end of each module, but they do a very nice job of explaining things. So if you'd like some more information on trauma-informed care, watch our follow-up email with the recording link and other information. So wanted to share that.
Okay.
Okay.
So the key items here that I really want you to go through is, again, that it's a mix of from trauma survivors to things that even have been healthcare. People that have gone through cancer treatment can be traumatized. I mean, it's not one avenue. It is wide and broad, which is why this questionnaire that you're using is important. So there are some probe questions, although they don't want you to call it a probe. That's where I said you don't have to keep asking the person, you know, more and more. They don't have to. If they say that they have childhood abuse, you write yes, and then these are the kinds of questions that could help you know what you would have to do while they're in your swing bed. So for instance, has this sort of come up in the last couple months? They use a 6 to 12 month period. Have you lost a family member, friend, and you notice they say a pet? Have you had any trauma that we need to know about, because we're giving you medicines and we want to give you the best care and we want you to heal from your surgery? Is there anything we need to know? Is there anything while you're in our swing bed program we can help? And that may mean, having to talk to their PCP. It might be talking, asking their minister to come in. Again, they are suggesting it. You don't have to suggest things to them. And then basically, is there anyone that you should contact? These are meant to be wide open questions. They are not meant to be this deep probe. But whatever, if any of this after they have answered your questionnaire or whatever you're using, these might help you define things as simple as activities, and in understanding what barriers to them getting getting discharged and better because of whatever that has put them in your Swingbed program.
Kerry, we have another question in chat. It goes back to the original question about discharging the patient and then admitting to acute. Does that mean that we would need to complete the paperwork for discharge and bed hold policy if the patient is readmitted to the hospital?
Yeah, it is a discharge. Your Swingbed chart closes at that moment, and whatever policies you have in place, that would be facility specific. They are admitted to ICU or acute, whatever that setting might be. Now remember this, there's two pieces to this, that's clear, but the second part is that, remember, we're not allowed to discharge from Swingbed for 24 hours, except in these cases, which is where they have been admitted somewhere else. So if they go down to the ED, for instance, we can't discharge them for 24 hours. We have to keep that open, even though they're in the ED and also getting charges in the ED. That's not a setting that we can discharge from Swingbed. If they're in the ED 24 hours and 1 minute, we discharge from Swingbed. All the other things, going to acute, going to ICU, we are discharging that patient, and then they're going to be admitted to that higher level of care. Does that make sense for everybody?
I believe so.
All right, and then this is the Appendix PP. If you don't know it, it's the State Operations Manual. PP is the questions that surveyors can ask you, and that's why I put that PP quote there. You can look at that. If you have not looked at Appendix W for critical access hospitals and Appendix PP, which is for surveyors, and the State Operations Manual, somebody on your team should be reviewing that, because that's how surveyors come in loaded for bear with specific questions. All right. Does that help? We're slightly over on your time,
Yeah.
but I hope just answering questions and stuff. This has been a lot today, so I don't expect these discussions to end today either.
We do have one other comment. Could you elaborate on the document distributed about having a Swingbed activities director?
Yes. All right. So the bottom line is, if you're critical access, I think I have quoted in there the answer or response I got from the CMS QSO office that says you are not required, by whatever date was in there, to have a certified activities director. Now, some of you still use an activities director, and that's perfectly fine. If you are a PPS Swingbed program, at this point, you do, until we get a query answered, and they haven't answered it yet. However, I want to draw a distinction. Just because you don't have to have that certified activities director doesn't mean you are clear and free and don't have to do activities. Activities is still required. That goes to back to that psychosocial comment, mental health comment that's in the regulations. You must provide activities. You just don't have to have somebody to lead them. So that's usually surveyors, because they're so used to long-term care, will be looking for a calendar. You can bring in non-pandemic times, you can bring in singing groups, you can certainly have ministers involved in this. You can have activities that are easier to do in their rooms individually because of our Swingbed settings, but you must not only have activities, you must have an activities assessment. Many, doesn't mean all, but many, both types of Swingbed programs have added the activities assessment to the nursing assessment. But you must set up some kind of programming, and you must have documentation that shows that you submitted activities that were valuable to that individual based on what their needs were.
Okay, so then in general, to review, you have to have a program, You're not, as a critical access hospital, you're not required to have an activities director, but to have the program to complete that assessment and make sure that activities are provided to the patient that are appropriate for them individually.
Correct. And I hesitate in using the word program because program refers that somebody's running that program. But yes, you must have activities, and it can't be something that's, one time while they're there. It has to have some thought. But you also know the types of patients you're admitting, and you may be able to get a more universal type of activity because of it, like orthopedic patients that are in bed. I mean, it can be the Sudoku books or the crossword puzzle books or whatever. I mean, there are lots of ways to do activities. And I think I've shared this story. I'll share it sometime when we have more time if I haven't with this group. I had a guy that was all upset. And when I went in to talk to him, it was as simple as all he wanted was the Western channel on the TV and he couldn't find it. I found it for him, went out and told the nurses. And then we documented that was his activity. He wanted to watch the Western channel. So it doesn't always have to be this great explosive things. I mean, I'm sure you try and do things for holidays and birthdays if somebody's in your facility, but short of that, there are some simple solutions to this. But you, as critical access, do not have to have that certified position at this point.
Okay. Other questions? We recently distributed, just to kind of review, we'd recently sent information on PPS and CAH Swingbed activities programs, documentation on the facility initiated discharge, NOIG, some guidance for unnecessary drugs and psychotropic drugs, and then a little bit of information on the Office of Inspector General work plan for 2021. So I will reattach those to the email that will provide the recording link to today. We'll also, Kerry will get me the information for billers for the 3-day stay. So those are not, or 3-day waiver. So those are not denied. And I will also send the link for the trauma-informed care module that is provided by Indiana University. Anything else, Kerry?
No, I think that's enough to make us all have to think for way too much at this point. So yeah, I'd say go enjoy lunch and then hit the salt mines again.
All right. Well, thank you so much. Thanks everyone for joining. Again, we apologize for Zoom not working quite right today. Just one of those Zoom quirky days. And if you have any additional questions, feel free to reach out. We try to respond as quickly as possible. And watch for the email with all of the information and follow up to today's call. Have a wonderful day. Thank you so much.